if we want to do efficient analysis, we really need to efficiently categorize these variables if you want to use larger data masses. Today, I'll be talking about the utilization of uncategorized medical data, and I will be presenting a case from the Finnish specialized care. And also, like the very nice introduction said, my background is in medication safety and clinical pharmacology. So how I ended up doing this particular research topic, I would like to give you a bit of a background on. So from the start of my research, I have been utilizing the Finnish healthcare registers, and luckily for me, we have plenty of those. We have, like shown in this picture, which does not contain by far all of the registers we have a lot of nationwide registers, and you can really say that Finland is the promised land of healthcare registers. And why we have these registers is a result of very aggressive digitalization in the late 1990s. So we're really happy about the situation right now. Majority of these nationwide registers contain categorized or semi-categorized data. And they all approach the data from a bit of different angles. So we get a large variety of different data variables. But in addition to the nationwide registers, we do have more localized hospital data lake registers, which tend to document all variables that are documented during patients' care in healthcare, whether it's specialized or primary care. And it's collected from a specific area, typically from a university hospital area. And what's the difference between the nationwide registers and the hospital data lakes is that the hospital data lakes do contain a lot of narrative data as well, because they include all kinds of patient statements like pathology statements and radiology statements. So what's in common to all these registers is that they contain individual level data. And what's really nice about them is that they're all linkable via social security number. So us register study people in Finland, we really have it nice here. Because of course, from this type of register connection, we can combine a lot of different information of patient care. So we seem to be having plenty of data in categorized form. So what's the fuss about uncategorized data? Well, the thing is that when doing research, you quite quickly realize that categorical data tells a lot about healthcare and pharmacotherapies, which I am interested in, but it also leaves a lot of things and a lot of questions out. And examples of those are whether patient can actually take the medicine he or she is prescribed, or whether patient experiences adverse drug reaction during treatment. Categorical data doesn't really tell a lot about medication process itself, or whether patient experienced treatment failure, or let alone the cause of treatment failure, and what was the overall patient experience during the treatment. So as you may tell from these questions here, many of the uncategorized or unstructured variables measure the quality of pharmacotherapies. And that, of course, is the reason why I'm so interested about the uncategorical data. And so in uncategorized format, we have descriptions of larger events like adverse drug events and medication errors and the overall treatment. But sometimes, as a result of the way these variables are documented, we can have essentially structured variables like left ventricle ejection fraction and ECOG and NIHA class that are or could be categorical variables very easily, but they're just documented within the patient text, so they are in uncategorized format. So, like said, my background is in medication safety research, so these are all things I'm very interested in. So very quickly, during my PhD work, I realized that if we want to do efficient analysis considering these events, we really need to efficiently categorize these variables if you want to use larger data masses to quantify them. So that is kind of the background on why uncategorized data is so interesting and important to us in my research group. So during my PhD studies, I used a lot of patient register data, but I also used national medication error report data that is collected from the Finnish healthcare. That medication error reporting system is called the HIPRO reporting system, and it was initiated in 2007 in Finland. And it contains information from social and healthcare organizations, and it currently has over 200,000 users. And I think the latest addition to the users of the HIPRO system were the private pharmacies that initiated the HIPRO system also back in 2021. So the HIPRO reports that you can see an example of in the right, unfortunately in Finnish, they are filed by healthcare professionals and patients. And just in specialized care, we have estimated that we get over 15,000 reports annually. So we get a quite nice number of reports, but we do know that that is in reality 5 to 10% of all events that occur. But of course, we take what we can, so it's already a good register of medication error data. So from the picture, you can see that the reports contain structured and unstructured data. And what is in unstructured form are the description of the event, the circumstances enabling the event, and future prevention ideas to, of course, prevent these types of events. So actually, these are the things that we are really interested in these reports. And what is in categorized format are event time, event location, the occupation of the person filing the report, and whether it was actual medication error or a near-miss event, the unit where it occurred, and then after the report has been filed by the person reporting it in the first place, it goes to the unit supervisor typically, who fills risk assessment and patient harm assessment according to a specific scheme. So these are also in a categorized format in the final report. Currently, we cannot utilize efficiently the narrative part of the reports, the unstructured part. The unstructured part is mainly analyzed in really small takes in unit level, typically. And on organizational level, we can only efficiently utilize the categorized data. And this, of course, leads to lack of systematic analysis of these medication error reports. And we don't get as good an overview of the medication safety issues as we would like to. And also kind of up-to-date information of trends and descriptions of new phenomenon in medication safety is left out in this way of analyzing the reports. So it's not very efficient. So the case example I'm presenting today is a proof of concept project that we conducted in collaboration with Oulu University Hospital, Oulu University, and Oulu DigiHealth Hub. And we had SAS Analytics that was taking care of the technical execution of this project. Of course, I didn't do this work by myself. I had a lot of help from my research group. And to name one person, Sami Snek from Oulu University Hospital was really working hard with the data categories in this project. And I would like to point out that because of my background in clinical pharmacology, I will by no means go into detail about the technical aspects of this project. This will be a very practical presentation of the work and the results. So in this work, we had a data set of 15,000 HIPRO reports from Oulu University Hospital that were collected from 2007 to 2020. And these were specialized care reports only, and they contained both actual medication errors and near-miss events. And in the image, you can see the study design coarsely. Our idea was to collect know-how from and IT solutions from private corporations, and also utilize our previous knowledge and on the analysis of medication safety incidents, and then just to use this new data that we had collected. And what we wanted to do was to test the capabilities of AI methods, specifically natural language processing, in analyzing and categorizing these reports. And our goals were to achieve automated data anonymization and also automated drug name categorization and event categorization. And this work is actually published in DOSIS. Unfortunately, it is in Finnish. Due to the nature of the project, it was a proof of concept project with very limited resourcing. We did not do very thorough. We did as thorough validation as we could, but it was not as thorough that it would be enough to report in international publication series. But it is published in DOSIS, and it has a abstract in English, so you can search that out. So a little bit of the background and our previous results. So like I said, we were very familiar with the HYPRO reporting register. And in the image here, you can see our research from 2020, where we had a take of a bit more than 9,000 HYPRO reports that we wanted to analyze and categorize. And here we had to do it manually. And because we had to do it manually, we had to really go down in the cohort size to make it really feasible. And the first thing we wanted to do was to select medications from specific ATC categories. And to do that, the first thing we had to do was to search and categorize all medicine that were involved in the reports. And after that, we did manual data processing, which included me reading through all the a bit more than 1,600 HYPRO reports, and then manually coding them according to incident types, and then grouping the incident types into coarse categories, and then creating the final categories. And in this study, we selected 5 categories that describe the outcome of the medication error, what actually happened to the medication itself after the error had occurred, whether patient received excess medicine or was omitted medicine, or had a wrong dose or wrong medicine. And then, of course, we had the undefined outcomes. So we were enthusiastic about this study, and that formed the main aim to the proof of concept project later, which was to test the capabilities of natural language processing in categorizing event outcomes, and also the medication data from narrative parts of the HYPRO reports. And at this point, we were not at all sure whether this kind of automated categorization, especially concerning the ATC coding, would be even possible. So our main interest was just to see which steps are needed in data processing to produce results with NLP methods, and whether it's actually even possible. So here is the process of natural language processing that we had in this process very briefly. So first we have our data set of 15,000 reports. And before anything, we had to do anonymization to these reports because, of course, the material is very sensitive. So that was the first step. And after that came the actual natural language processing, which consisted of tokenization, lemmatization, part of speech tagging, and sentence boundary disambiguation. And to those of you who are not so into natural language processing like me, this is all explained in English here next to the box. So basically, every text that was in the reports was first chopped into sentences and then into individual words. And the words were returned to their basic form, and they were coded and categorized according to the grammatic meaning and context of the word. So after this process, we pretty much just had words in their basic form and that were labeled. So they could be categorized, searched, and the associations of the words could be studied. And in the right, you can see just a very preliminary result of a word search after this was done to the reports, where we searched for the word error and just wanted to see which kind of other words and associations to other words the word error would have. And the picture kind of depicts the positioning of the words and also the strength of the correlation. So this was already pretty informative, that picture itself. And then to the ATC classification, which ended up being really just the main issue to solve in this proof of concept project. And this was the thing we were most uncertain of whether we could do it or not. So to those who do not know, ATC classification stands for Anatomic Therapeutic Chemical Classification of Medicines, and all medical substances have a 5-level ITC code that just all marks in the ATC code have separate meaning. The first one being the ATC main class. And the thing with medical data overall is that the medical categories always tend to be a bit overlapping and often hierarchic. And based on our previous research, we knew that this was also very much the case with ATC classification. And our main concern was that several medicines have overlap in their classification, meaning that they have multiple main classes. The same substance may have multiple simultaneous main classes. And examples of such medicines are metronidazole, acetylsalicylic acid, lidocaine, and cefuroxime. And here you can see more specifically the case metronidazole. It has, at the same time, it's categorized in 5 different main ATC classes. And quite often it had several preparations with similar names also in these classes. So the classification required for us to do some tricks. And quite often we had to take words that describe the pharmaceutical composition or administration route to kind of identify the specific medicine and to make sure it was categorized properly and in the right class. And luckily, we did not have to start this work from scratch. Like I said, we had been doing this classification manually in our previous research, so we already knew the problematic medications. So we had a list of those, and we could just move straightforwardly to the creating the rules of the classification. So that helped a bit. So let's go straight to the results then. First up, anonymization. So in theory, medication error reports and hypo reports are spontaneous reports, and they should not contain any individual level information. But in reality, they do contain phone numbers, emails, names, and even social security numbers. For whatever reason, these information are sometimes put into the narrative part of the reports. And on the right, you can see examples of such cases. They're not actual reports, of course, but very realistic cases of situations where individual level information would be in those reports. So the anonymization here was conducted using SAS via peer exchange function to remove any personal information from the reports. And basically that function found the selected string from within the text and replaced it with a selected other string, with ours being the XXX. And the challenges we ran into during the anonymization process were that, for starters, our electronic patient register names were Esko and Antti, which are also common Finnish male names. So we had to exclude these from the lists with specific rules. And also we noticed that there was a fine line balancing between erasing names in the text from the text, and still maintaining the analyzability and readability of the data. And also Finnish language posed some some specific concerns also. For example, the function considered ole first a name, which it definitely is not in Finnish. It's a verb is. So we had to kind of go through the data many times in several iterative rounds to make sure that we did not mess up the data, but still ended up with good anonymization results. And we basically did this by cross-examining reports that were anonymized with those that weren't anonymized. Then to the ATC categorization. So from the ATC categorization system, we had over 11,000 categorizing terms alone. So we had all brand names of drugs and all active substance names. But in addition to those, we wanted to have medical slang names that were used for medications, DXAM for dexamethasone and EPI5 or EPI7 for epidural anesthetics, for example. And also from our previous experience, we wanted to add the most common typos, because drug names are hard and they're quite often misspelled. So overall, our ATC search found over 35,000 hits from the 15,000 reports. And what we had to do to achieve this, in addition to the 11,000 categorizing terms from the basic ATC classification, were to add 88 special rules for brand names and over 2,000 special rules for active substance names. So doing this to all those individually was quite a lot of work, and Sami really had to pull some stunts here to make it work. So it took a lot more time than we anticipated. And that was also the reason why the validation was, we did not end up having enough time for very thorough validation, but we did compare these results that we received from this data to the nationwide data that we had analyzed previously. And we, like said in the beginning, did not have any intention for quantification. So we're just checking the capabilities here. So like you can see from the picture here, already we're enriching the data a lot by just adding the ATC categorization information here. And it is actually very important information if it's not achievable otherwise. So here we could make longitudinal analysis, and we could filter the reports according to any selected medication class or any selected time period. So we could really just see whether there were any trends in the medication errors overall during the period, where if some group would peak in a certain time, you could kind of specifically go into there and see what really happened during that time. So it was really interesting. So we could now basically detect every medicine mentioned in the reports. And when we compared the results we got from this ATC categorization with this cohort, we were really pleased to see that the picture depicted here on left, that these results of the overall ATC categories and the distribution of them really matched our previous studies. So they're pretty much identical results to our previous studies. So even though we couldn't make a real specific validation, this gave us optimism that we were doing things right here. And the really nice thing about adding these ATC categories to the variables was that we could combine them now with any other categorical variables from the results or from the reports. Like you can see on the upper right picture here, we just combining the ATC hierarchy to the medication error type gives you a lot of quick understanding on how the medication distribution goes within the errors. And then also below, you can see that we just kind of filtered the group NO2 and wanted to see how the risk and patient harm was distributed within the medicines in this group. So this was really a huge step forward in the analysis process for us. Then after spending several hours on this work, we finally got to the event categorization itself. And we ended up not having very much time to do that. So we selected a few event types that we wanted to search from the medication error reports. And we ended up with categories describing lookalike sound-alike medicines, staff alertness, administration route, electronic patient record system, and some of the medication outcomes that we had researched in our previous work. And the search rules were basically word combinations, and we use very basic rules, distance, not rules, and associated words to create the searches. And for administration route, we had to use some synonym words and slang words because it turned out in Finnish language, you have very many ways to say that you give something intravenously. So overall, our finding of this process was that Finnish language will make us work a bit more. Like you can probably tell by this picture where you have all the, I don't know if inflection is the right word, but you have all the forms of the word dog. So this is also the reason why many of the standard solutions that are offered by different software do not work well with Finnish language. So we don't have any easy or given solutions for us, unfortunately. But luckily for you, this is probably not the case with Norwegian language. So the results from the event categorization were pretty much similar to those with the ATC categories. We were really happy with the results, and we were enriching the existing data with knowledge of these phenomenon. We found 134 reports with lookalike sound-alike medicine hits and 135 reports that mentioned staff alertness. And the kind of part that we were happy to see was that over 2/3 of the reports mentioned electronic patient record system, which gave us the idea or kind of, we already knew that information transfer is the root cause for majority of events everywhere in the world. So this kind of just emphasized this idea here. So we could now use the event categories with ATC categories, but also with the existing categorical variables from the medication error reports. And below here, you can see a picture where we have the administration route combined with harm inflicted to patient. And the results are really just, they make a lot of sense given that per oral administration is hardly ever considered causing serious harm to patient, whereas intrathecal administration is significantly more often considered to cause serious harm to patients. So the results made a lot of sense to us, and we're really happy to see these to come alive, and also that the analyses were so fast to do after the initial categorization. On top of our work with these categories, there was a small bonus also that we weren't expecting, but came without ordering. So while the text is processed in the reports, the software formed word combinations, where it kind of combined words that were more often associated with each other or clustered. And below you can see an example of such topic that was built by the software itself, where there's the word pain, surgery, anesthesia, pain medication, and operation room. And when researching these topics, we discovered that yes, these are very common kind of events, and also that in this way the data kind of starts telling you what goes on in the reports without you having to think what you want to find from the data. So this we saw as a step towards more refined methods with AI in the future, or possibility of such work in the future. So last, the conclusions and next steps. Like said, this is by no means bulletproof because of project resourcing and time, unfortunately. Our validation based on iterative rounds and assessing small takes, so it does not rule out false negative results. We can easily have unfound medication or unfound outcome events in the reports. But overall, considering the validation we could do, we're really happy and really optimistic about these results. So in the future, further validation and testing is required. And also we should pretty much increase data numbers and add more sophisticated machine learning methods to the analysis process. And this would require just a lot of more interdisciplinary research and development work from us. And in the far future, we kind of envision that this kind of work lays the basis for any further development, and maybe once we get this going, it could even be integrated to electronic patient record systems, where it could work as a real-time detection of events. And this is also the way to form a basis for any effectiveness assessments. So that's really, we're really looking forward for the future. And in the future, we kind of, from this project, our take was that in the future, we're really looking forward for the data telling us what we want to know, instead of us telling the data what we need to know from it. And to the end, I would like to highlight a bit of the importance of this work. In January, we had a huge healthcare reform in Finland, where we said goodbye to our old hospital districts and said hello to new encatchment areas that are now covering healthcare, both primary and specialized care in Finland. And one of the main goals of these new encatchment areas here is to ensure that medication in the future is knowledge-based, and also knowledge-based decision-making kind of guides every process that is developed here. So this kind of work is really important, considering that in the future.